Okay, so we are now recording. Okay, we are doing bullous diseases today for those joining us remotely.
Do you want me to go?
Sure. Yeah, that's fine.
Looks like there's a little bit of a blister or separation, subepidermal.
Subepidermal.
And then I think that might be like neutrophil necrosis.
Yeah, there's certainly a lot of artifactual change, and some crush there.
Yeah.
But it does look like there's some neutrophilic debris. So some fibrin and neutrophilic debris in the papillary dermis might make you think of what group of disorders?
Plaid differential.
And so plaid includes?
Bullous pemphigoid, lupus, linear IgA, EBA, and DH.
Yep. And lupus, we're usually referring to bullous lupus there. Yeah. Although acute systemic lupus, you can, even when it doesn't form bulla, you can have a neutrophilic infiltrate early in acute lupus. And in this case, it all comes down to the IF, and in this case, it was linear IgA.
Okay.
Have you guys seen good images of IgA patterns in DH versus linear IgA? Linear IgA really looks like toothpaste spread along, whereas DH is not only granular, but the granules are vertical. It's a picket fence pattern because they're along anchoring fibrils. So when you look really close at the granules in DH, they really do have a vertical orientation, like a picket fence. And you want to see that to establish the diagnosis if you're going to call something dermatitis herpetiformis. Let's see what we want to do here.
So it looks like there's precantholitis or a little small blister. Kind of looks intraepidermal, maybe subepidermal. They look like maybe there's some newts in there.
Yeah, so there are definitely some newts, and the question here, it's not clearly a subepidermal split. I agree with you that the newts are kind of sitting within the epidermis, not necessarily high, but definitely within the epidermis. There could be a little reepithelialization below, but it looks like rather than being a clean split, you have some necrotic keratinocytes. You have necrosis of the basal layer. So thoughts?
Maybe more along like the EM spectrum.
So that's a very good thought. Could it be something EM, TEN, fixed drug, and then the neutrophils would be that there is some erosion or excoriation out of plane of section that's recruited the neutrophils. That's a very good thought. There are some individual neutrophils lined up along the DE junction. This one turned out to be chronic bullous disease of childhood. And what I suspect is the linear array of neutrophils is the immunobullous disease. It's incredibly pruritic, and there was probably some excoriation adjacent to this field, which is the necrosis and the neutrophils. When you have mixed patterns like this histologically, then the IF becomes particularly helpful. Great. There's all lot of DH in this box.
Very broad shade. It looks like we have, I want to say subepidermal split.
Agree.
With some neutrophils. Could be.
And what are the red things with 2 nuclei and coarse granules?
Those are eosinophils.
Those are eosinophils.
So with all that, it could be BP, given the inflammatory infiltrate.
Yep, and every time you say BP, you also have to consider
EBA.
So anytime you say BP, you have to consider EBA as a possibility. The EBA ones tend to be the ones that are more refractory to treatment, the ones that some are more likely to have milia and sometimes scarring, and the ones that are more likely associated with systemic disease, including malignancy. BP by itself is probably not very associated with any of those things. Other things that can do it, bug bite, scabies, you have to remember those things as well. This one was BP, but your IF pattern can be helpful. What do you expect on immunofluorescence?
For bullous pemphigoid.
For pemphigoid.
You have IgG and C3 along the basement membrane. And then for EBA, I think it's U-striated pattern for the immunofluorescence.
For EBA.
For EBA.
And for pemphigoid N. So it looks like a sine wave versus spiky inverted U's.
Looks like the striatum is just gone here,
So corneum's gone,
which makes me think of maybe it's foliaceous.
which makes you think of foliaceous, and if it's in the granular layer split, that would certainly be good for foliaceous. The other thing that you have to consider is that vulgaris can have reepithelialization, right? So in this case, that split looks like it's below granular, right? So maybe more likely vulgaris with reepithelialization rather than foliaceous, which should really split just like staph scalded skin in the granular layer. And it's very common if you get a little bit older bulla that you're going to have reepithelialization like that.
Looks like we have some acantholysis. These red cells involving all layers in some areas, but mainly just above the basal layer. It looks like. I would think about Haley.
So, what color are the rings around the nuclei?
I guess that one's bluer.
Some of them are blue, some are clear, some are red. Is that a Haley pattern?
No, they should be all red.
So Haley only knows how to do red rings. Okay.
I think it's vulgaris.
We have a lot of corons, right?
Rovers and Derriers.
Yeah, this is more a Grover's Derriers pattern. So how it differs, this pile of corons that you have here of dyskeratotic cells, you'd never get in Haley. So that's more a Derriers Grover's pattern to have real stacks of dyskeratotic cells. Many of the circles around the nuclei are blue, whereas Haley only does red. You have clear halos as well. So again, that's more Grover's, Derriers, vulvocrural dyskeratosis looks similar. whereas Haley would be dilapidated brick wall and only ever red rings. Let's see. Got lots of repeats here.
I don't see any corneum. I'm not really sure exactly the site that we're looking at here. Potentially mucosal.
And that could be corneum, right?
Mm-hmm.
Parakeratotic corneum. And I
There's
agree.
maybe
It
a
looks
little
like
bit
it's
of acantholysis right there in the corner. Like a
so right
pemphigus.
there in the corner. That's about what you get. So you might think, of the possibility of pemphigus. If this is mucosal, is that more likely vulgaris or foliaceous?
Vulgaris.
And so why does vulgaris hit mucosa and foliaceous doesn't?
There's no desmogleon 1 in mucosa.
Yeah, exactly.
Sure.
And the other thing to be cautious of is when your skin of your vulgaris patients look great, but they tell you they're still having mucosal symptoms, like the patient we had Friday in East Cooper, where her skin looks great, she just has oral erosions, but she says all the way down her throat it bothers her. That can be serious trouble brewing because there are 2 glues in skin. So if you target desmoglein 3, you still have desmoglein 1 holding your skin together, but you only have 1 glue in mucosa, right? And it's the one being targeted by vulgaris. So you often have mucosal disease out of proportion to skin disease.
So we have some hidden epidermis there. It does look pretty dead and necrotic.
Looks
Yeah.
pretty dead, so it's sloughed off.
Yeah, I was thinking like Stevens Johnson's TEN
Yes.
from EM.
So EM spectrum disease, EM, TEN, Stevens-Johnson, which would be very, very reasonable. What if you had an EM-like picture with a little bit of acantholysis and it's a 80-year-old man with eyes and lips involved?
Paraneoplastic pemphigus.
So PNP. So a PNP patient is going to look like an older Stevens-Johnson patient with eyes and lips involved. Okay. Often an older with the dwindles patient with a Stevens-Johnson looking clinical. And then depending on the varying degrees of acantholysis and dyskeratosis, it can look very, very similar to EM histologically. Often the acantholysis is minimal and the dyskeratosis and necrosis predominates.
Intraepidermal split and acantholysis. Could it be PV?
So it certainly is a split like PV. What do you think about these?
Dyskeratosis?
Dyskeratosis, does that go with pemphigus vulgaris?
No. Could
So
it be global?
yeah, exactly. So this would be more likely a transient acantholytic dyskeratosis with a pemphigus vulgaris-like pattern, but also with dyskeratosis. So mixed patterns of acantholytic disease, more likely so-called TAD. There's nothing transient about TAD, right?
Crusty over here. Looks like maybe in the granular layer there's some separation. Maybe some dyskeratosis as well.
There's definitely dyskeratosis here, right?
So,
You have corons.
Yeah. So it could be Darius or Grover's again.
Yeah, Darius, Grover's, vulvar curl, dyskeratosis, any of the ones that will give you a Grover's-like pattern.
It's like a subepidermal split.
Subepidermal split, and what's here?
This here looks like a lot of fibro around kind of east-west of scar.
Yeah, exactly. So you have fibroblast east-west and vessels vertical.
Like EB or
Yeah.
EBA.
So pemphigoid is probably less likely to scar than some of the other immunobullous, and here you're really seeing dermal scar with it. Makes you think of the possibility of cicatricial pemphigoid, which the name implies, right, likes to scar. Epidermolysis bullosa, which is more likely to scar. And then it comes down, of course, to the immunofluorescence pattern as well.
I think about Hailey.
So you think about Haley disease. It looks like you have maybe a little bit of dyskeratosis in here. By history, apparently this patient had positive immunofluorescence for pemphigus vulgaris. It's an unusual number of dyskeratotic cells. There really are some, what look like some corons there. So,
Grover died.
yeah, it looks more Groverish. Presumably the diagnosis was made with immunofluorescence, but that's a couple of standard deviations from norm.
We got a subepidermal split, some reepithelialization.
And some necrosis of the epidermis.
Think about PNP or EM.
So EM, TEN, PNP. There are some neutrophils. That could be just because you have an old necrotic bulla that's become a little impetiginized. Or could it be immunobullous and the epidermis becomes necrotic after it's been detached for a while? So it becomes chicken or the egg, right? And you need to look at the patient and you need to look at the immunofluorescence. In this case, immunofluorescence was positive for linear IgA. But it could be just as likely histologically that this was an EM-TEN-like picture with now some reepithelialization, and that the neutrophils are just secondary. So that's why, it's a nice example of how without the clinical and the immunofluorescence, you can't navigate your way through some of these.
Intraepidermal split. Looks like there's a good amount of necrosis.
And your corneum
Looks fairly acute.
looks pretty acute.
So, I would wonder about EM spectrum.
And clinically, this patient, it started after phenytoin was started as a drug. So where along that spectrum is the patient likely to behave?
Like SJS,
Yeah, more like TEN. So Stevens-Johnson tends to be sulfa mycoplasma.
Okay, yeah.
TEN tends to be nonsteroidal anti-inflammatory drugs and anticonvulsants, and EM minor tends to be herpes. So the trigger pretty much defines how they're going to behave. Let's see. Trying to get you a little variety here. It's probably good.
Split books. I think it's subepidermal.
Yep.
Probably like a BP, EVA type picture.
And in this case, it was disease limited to scalp with a lot of scarring, no mucosal involvement at all. So, you know, one of the things you would think of there would be Brunsting-Perry, which is cicatricial pemphigoid that's not mucosal at all. It's usually localized to scalp.
Yeah. Just totally upset. Try to get it. Do another box.
We're going to go to potpourri in just a moment. I want to do just a couple more here. Let's see. That one. Let's do.
Don't see corneum. It looks like an intraepidermal split. I'm not sure if those are dyskeratotic cells.
So do it. So if you're not sure, do it with and without. What if they're just acantholytic?
If they're just acantholytic,
Which one?
then more Haley.
Does Haley do hair follicles?
Not so much.
Not so much, right? In fact, one of the ways to treat Haley, in the days before naltrexone was used, was to vaporize everything, force it to reepithelialize from pilar epithelium because that was seldom affected, and people would get long-lasting relief from that. So typical for Haley is that it typically spares the follicle. What loves the follicle?
Pemphigus vulgaris.
Vulgaris
Those
loves
tracts down
adnexal
there.
structures. Yeah. So. And so this one, you kind of just have a late ulcer with lots of fibrin. IF was positive. It started in a radiation port for breast cancer, and it's very, very common for both pemphigus and pemphigoid to start in sites of either solar or therapeutic radiation burn and then generalize. So having an immunobolus disease start after a sunburn or start within a radiation port is a very classic presentation. So someone who has sort of chronic impetigo after their radiation therapy and radiation dermatitis that's kind of crusty and macerated and just won't get better, get a biopsy and get IF because they may well be starting with a course of immunobolus disease. Let's grab the potpourri box.
Yeah, the patient.
Which number?
Just pick at random. You are the king. You get to pick. Here we go. To the side a little bit. So first off, what do you have here?
Seborrheic keratosis.
Seborrheic keratosis, and then what happened? Is this a happy seborrheic keratosis?
No.
What's happening in this seborrheic keratosis?
Cells are kind of clearing out. Irritated. Trying to see if that's
What do you think about nucleocytoplasmic ratio?
it's high. Swing or inside too.
Yeah. So it's Bowens arising in a seb, which definitely happens. So, seb gone bad with Bowens.
Looks like you have a clear cell proliferation hanging off the epidermis. Trying to see if it palisades or not. I don't think it does.
I agree with you. I don't see any palisading at
Acrospiroma
all.
group.
So something in the acrospiroma group, and you said hanging off the epidermis, this little duct there. So pretty good for peroma. But definitely something in the acrospiroma group.
Yeah, atypical squamous proliferation here. Lots of clear atypia. Looks like a probably squame.
Yeah.
A lot of keratin burrows.
Give me the peace sign.
Exactly. So, definitely atypical mitotic figures. It's still keratinizing, so it's still moderately differentiated despite the high-grade atypia. Poorly differentiated shouldn't keratinize at all.
Very small. Looks like being tagged.
So they look like tag-like structures that were removed from the patient, probably multiple. And what is in these tag-like structures? Do they look?
Neurofibroma? No.
So neurofibroma, or I see some, kind of stellate pyramidal.
Angiopistoma.
So I'd go.
Angiofibroma?
Yep, I would go with angiofibroma. And if there are multiple angiofibromas on this patient who had seizures and periungual angiofibromas, yeah, tuberous sclerosis. What other syndromes can have multiple angiofibromas? MEN, which one? MEN1, what else? Birt-Hogg-Dubé. Those would be probably your biggest, right?
All right. So, the keratin in there. Papillomatous. It's not particularly warty.
Not exophytic warty, but there
Right.
certainly is hypergranulosis and some round parakeratosis in it.
Right.
Kind of a glassy red epithelium. Looks like it's starting to bud downward with.
Like a
I don't see any of the inclusion
Okay.
bodies like a myrmecia.
like maybe a KA.
Yeah, like early keratoacanthoma, which can be very warty. In fact, there's some evidence that they may, at least some of them are papillomavirus induced. And they start with hypergranulosis in the follicles and then start to bud outward with the very glassy proliferation. So early Ka sounds pretty good.
Punch biopsy. So there's some mild inflammatory cells kind of tracking down the hair follicle.
There are some inflammatory cells tracking down the hair follicle. Big picture view here.
It's kind of paucicellular and hypocellular.
Kind of paucicellular, hypocellular, and the cells that are there are characterized as
Kind of spindle shaped.
spindle cells with lots of new ropey collagen, forming sort of whorls and nodules.
Yeah, it's a scar.
Yeah, like hypertrophic scar. And if you had one stain to prove it, what would you do?
CD something. Very cool.
How about, I would probably do an elastic, right, to show that it's all gone in a scar. Okay.
They also have like adnexal structures that threw me off.
Let's take a look.
Maybe not on up top.
Yeah, you've lost them up top, you have preserved them down below. So there's not total loss of adnexal structures because it's a more superficial scar.
Okay.
It's melanocyte. I think about the melanoma you said.
So I agree with melanoma in situ. So it's melanocytic. It's poorly nested at the junction. You have areas where poorly nested units predominate over nests. It extends down adnexal structures. Nests are bizarre in shape. They're not regular in rhythm. They're not equidistant from one another. They're areas of confluence. There's zipper sign where, because you don't have desmosomes, the melanocytes separate from the underlying tissue. For all those reasons, yes, melanoma in situ.
Punch.
Looks like we got two pieces here, that one and this one.
Some scattered lymphoid infiltrates, vascular, interstitial. There's a lot of neutrophils.
Yeah, neutrophil debris, all kinds of things going on.
LC,
So you'd wonder about an LCP.
giant cells. There's
What
a
about your
clot.
dermis and cellularity?
It's a little hypercellular.
A little hypercellular, and is it more hypercellular superficial or more hypercellular deep?
A little deeper. Those lollipop bodies are gonna say.
Those are lollipop bodies like NSF, and then the neutrophils, I don't know what that's all about. But, there may have been some ulceration or something adjacent that gave it. But busy dermis, and it's bottom heavy. Plus the lollipop bodies are osteoid forming around elastin or elastic fibers. Are pathognomonic for nephrogenic systemic fibrosis, which is still out there. You still see people who had their studies some time ago and are still showing up with disease.
So, got some kind of pale pink like structures in this. Not sure what those are.
And so what kind of tissue do you think that is?
Collagen. I'm not sure.
When you look at the nuclei, are they pointy or are they more blunt?
They're more blunt, so that muscle.
And you have little vacuoles, little glycogen snacks there because they're working hard contracting. Right. So if that's all smooth muscle, then what would you think?
Smooth muscle hematoma.
Smooth muscle hematoma is when they're all lined up looking like excessive erector pili, but all in normal orientation. Is this all in normal orientation or kind of haphazard? So more haphazard. So maybe a punch out of a leiomyoma rather than a smooth muscle hematoma. And this person has leiomyomas in a segmental distribution. So that could be loss of heterozygosity in that segment, but they could have a germline mutation, which is fumarate hydratase, which would be associated with Reed syndrome, and Reed's important because they also get
Kidney malignancies.
so kidney, what kind? Oncocytoma?
Sure.
No.
I don't know.
That's the one that you get with Birt-Hogg Bay.
Okay.
It's renal papillary carcinoma, which is much worse,
Okay.
is what you get with Reed. And then they also get uterine leiomyomas as well as the cutaneous leiomyomas.
So all this, the palisades, I would say trichomoma.
They are clear, they palisade, they have a thick red basal membrane zone, so you are correct, trichomoma. Well done. Someone needs to pass that easy button.
Some large nodules of basaloid cells.
So when you say large nodule basaloid, you're suggesting that it's predominantly blue, right? Blue tumor, clear cells. Blue tumor, clear cells, or blue tumor, red duct would both be.
So, I mean, like a sebaceum or
So sebaceous. So blue tumor, clear cells, blue tumor, red duct would both be sebaceous. Sebaceomas tend to be very well lobulated and have very prominent red circular ducts. Don't really see that here. So less likely sebaceoma and more likely
sebaceous epithelium.
sebaceous, at least epithelioma or carcinoma. That one had some areas of necrosis, suggesting maybe carcinoma. Let's see. See if we got a better. Yeah, I mean it probably is basal cell. Any kind of basal cell that has pink strands and blue buds. Yeah, so it's probably, this is sort of a cross between a superficial and an infundibulocystic. You can see how the pink strands can mimic tumor follicular infundibulum. And sometimes in a small biopsy you can't tell which of those it is.
So punch biopsy, some lichenoid infiltrate.
So punch biopsy band-like infiltrate.
Or exocytosis.
Tell me about the collagen.
Light pink, like linguine, like collagen maybe.
Yeah, you've got ropey collagen in your papillary dermis, right? So that counts as papillodermal fibrosis.
MF.
I mean, that makes you wonder about MF. I don't see a lot of epidermotropism here. This is from a patient with mycosis fungoides, and your clue is just that you have something that's a lichenoid infiltrate. You have a lot of papillodermal fibrosis. So that should raise suspicion right there.
Looks pretty nasty.
It's pretty nasty.
Melanoma.
How about on this side?
Nevus.
Nevus.
And then a melanoma on the other side.
Nevus, and then melanoma rising in. Nevus, about, I mean, depending on the study, somewhere between 20 and 40% of melanomas arise in pre-existing nevi.
You have a big nodule of pinkish cells.
Big nodule pinkish cells.
I'm thinking granular cells. It doesn't really look like that up close.
Yeah, they're not granular. There are lots of EOs in here. But what are these background cells that form syncytial giant cells?
There's like histiocyte.
Yeah, probably histiocytic. So what kind of things would give you EOs on a background of histiocytes?
I'm not sure.
Do you know any kind of granuloma that's eosinophilic?
Eosinophilic.
So eosinophilic granuloma could be one, right? So it could be in the more granulomatous end of a...
Groundhog Day.
it is like Groundhog Day. Like a Langerhans cell histiocytosis granulomatous end of the spectrum. Reticular histiocytic granuloma can sometimes have lots of EOs, even juvenile xanthogranuloma can have lots of EOs, and rarely Rosi-Dorfman can, but those would all be things that you'd
What would you
consider.
favor on that one?
I'd stain it. So I'd put a Langerin on that.
Okay.
S100, both Rosi-Dorfman, actually some JXGs, as well as LCH, they can all be S100 positive. So CD1A or Langerin would probably be more informative.
Okay. Looks like observation in the center or not on the cartilage.
So you have some ulcer, some fibrin, some granulation tissue, chondrodermatitis nodularis, chronica helicus.
Go for it.
Little small little shave. One is compact. Not super excited about the epidermis overall. In the dermis, there are some grayish cells
Yep.
scattered throughout.
Are they scattered or are they nested?
Well, they're nested, so it's probably melanoma. I'm wondering if it's metastatic, if it's not coming from.
So there really is nothing at the junction, which is what you're
Right.
pointing out, right?
Right.
So look it up on the screen.
Uh-huh.
They're large grayish cells. They have vesicular
Yeah.
nuclei. They have a single nucleolus. They disperse with depth. They're large, spindle and epithelioid. They have a vertical orientation, like they're raining down.
Spits almost?
Is there any?
Intradermal?
It's an intradermal spitz.
Oh, okay.
Very good.
Needs to be a little effacement of the epidermis. I don't know what those black things are. If that's artifacts.
So that's probably calcium.
And There's some kind of spiky little islands.
So little islands in the desmoplastic stroma. There are humps on both sides and a depression in the middle. How might you characterize that? A dell, a central dell. So you have calcification, you have horn cysts, you have paisley tie in a desmoplastic stroma, a central dell, desmoplastic trichoepithelioma. Exactly. There are some other things with a central dell. We had a year-end skid where people were asked the Dell differential, and they started with desmoplastic trichoep, ended up with the oracle at Delphi and other things. And, it was funny at the time. I guess if you're overworked, all kinds of things become funny.
Extensive lymphocyte infiltration.
Yeah, highly inflamed.
Ulcer.
An ulcer. And what else is in there? Why is this thing so highly inflamed? Anyone want to jump in?
Oh, this contagion.
Yeah, exactly. Those are all molluscum bodies. So molluscum dermatitis and inflamed molluscum, it's 99% inflammation, and then you have your focal molluscum bodies that tell you what's going on.
It's kind of near small, round, monotonous cell death. Probably
Yeah, something in the acrospiroma group. It's small polygonal cells with cytoplasm. There's no palisading whatsoever. So that's typically going to be somewhere in your acrospiroma, poroma group. You could call that a hydradenoma, you could call it a dermal duct tumor, it's all the same thing. Right? How are we doing time-wise? About 10 more minutes.
Also got a melanocytic proliferation. There's a lot of pigment that's kind of deep.
So you have clearly two populations of cells, right? You have this population out here, and then you have this population that has ample dusty gray cytoplasm, small hyperchromatic nuclei, inconspicuous nucleoli, smudged chromatin pattern. Anyone want to jump in with a thought?
so like a DPN, combined.
Yeah, so a combined nevus,
It was a combined, but what were you describing with that actually?
deep penetrating nevus
Okay.
population. So deep penetrating nevus has the ample dusty gray cytoplasm, small hyperchromatic nuclei, inconspicuous nucleoli, smudged chromatin.
Okay.
And that combination of banal and deep penetrating nevus like NAS was the most common combined nevus sent in for consultation at Tulane, so Dr. Reed called it the common combined nevus.
One side there's some pretty compact hyperkeratosis, might be an ankle site. Ow.
Porokeratosis, so that's a cornoid lamello with the dyskeratotic cell.
Should have stopped her.
I thought you were being all. It almost looks like a sub.
Yeah, it looks like a seborrheic keratosis, and what's going on in the seborrheic keratosis?
lots of larger cells, or I guess it could be like Bowens or Paget's.
Like Bowens or Paget's, they certainly have that amphiphilic pagetoid look. It's not clear whether they're at the basal layer or crushing a basal layer. At least this nest suggests some crushing of a basal layer. And this was, in fact, a seb on a woman's breast with the Pagets growing into the seb. Clear cell papulosis in a younger woman where there are multiple lesions would be, those are Toker cells, which are probably the primordial cells that give rise to extramammary Pagets, right? But you can have a benign version of bland Pagetoid cells that's clear cell papulosis. This really was Pagets when the patient was examined. Find our tissue. There we go.
So you allow them anastomosing strands of epidermis, so kind of pink strands and say blue buds.
So anastomosing pink strands, blue buds. Infundibulous cystic radiates outward from a central follicle-like structure. This is anastomosing, so it's the other pink strand, blue bud.
Okay,
And it has lots of fibro as well as the epithelial.
oh, the pinkest.
Pincus tumor.
It's a baby.
So it's like a baby pincus. They got to start somewhere, right? Let's see.
I have a hair follicle with lots of hair shafts in it.
Yep.
A trichofollicular.
Yeah, it's a trichofolliculoma where most of what you're seeing is that central pore-like opening with all the hairs coming out.
Looks like you got a little bit of unhappy fat.
A little bit of unhappy fat.
They're different sizes, so kind of lobular.
And not much above. Got all these little round spaces. So you can, wonder what was in those little spaces. And in this case, history was prior injection for augmentation at the site. So probably a sclerosing lipogranuloma where some paraffin-like substance was injected.
What was the site?
Don't know. Could have been a lip or something. Although it looked like skin, so it would have been cutaneous, not mucosal.
There's some, maybe like necrosis and tumors there, or one of those ones.
Why is this composed of tiny little circles like that?
Like suture.
Like suture, and you can
Yeah.
see the knot
Suture
here, right?
granuloma.
So it's suture granuloma. I think we're there. Okay.
Thank you, Dr. Olson.